He moved to Houston in 2020 after practicing in his hometown of San Antonio. He's a graduate of the University of Texas, Plan 2 honors program, and he attended UT Southwestern Medical School in Dallas. He completed a residency in otolaryngology, head and neck surgery at the George Washington University Medical Center in Washington, D.C. So he was in Foggy Bottom probably when I was in Northwest. He is board certified by the American Board of Otolaryngology and a fellow of the American College of Surgeons. He practices general otolaryngology in the Kingwood office of Houston ENT and Allergy. He's a 2020 through 2021 president of the Texas Association of Otolaryngology and a director in the Texas Lyceum. As you all know, he's a member of Class XL of Leadership Houston, and he has served on the board of directors of the Behar County Medical Society, the board of trustees of the White Museum in San Antonio, and he was a member of Class 41 of Leadership San Antonio. So I don't know many of us who were in 2 classes of Leadership some city, but he was. Has he joined us yet?
He has not, but I sent him the link again.
Okay, well, he's coming. You know, a lot of us have gotten rusty now that on virtual meetings now that the hardcore pandemic is over. There he is, Dr. John. How are you?
Gotta love Teams. Microsoft doesn't, Windows doesn't like it.
That's hilarious. So I have updated the group on what an otolaryngologist is, and I've given your bio. So let's go ahead and just dive right in.
Wait,
all right.
There's still some announcements typically included.
Oh.
I included the list of announcements, and just so y'all know, we are recording the session, and I'll find a way to share the link with the greater group. But thanks all for showing up. Hopefully the announcements are easy to read, Shannon. Kind of set them up, hopefully.
I'm sorry, where are they?
I included them in the link with the that I emailed you and Dr. John like 15 minutes before.
Oh, with the Teams link or the original link?
It was the original email with I sent it to you and John with the agenda.
Okay, nope. Let me hold on.
It went to sarah.shannon.hunter@gmail.
Yeah, give me 1 second. Okay.
Sergio.
Is there a way for me to? Is there a way for me to share the screen on this? I don't.
Yes.
I see. Here's the link for your reference, but I don't. Oh, here it is. Okay, sorry. So yeah, this is why I went out of order because I hadn't seen this email. So the announcements. Congratulations to Key Wilson on her new role with Leadership Houston. She is the Director of Development and Outreach, and we look forward to her contributions. Congratulations also to classmate Patrick Rumpf on his new role at Legacy Community Health. And also, for the rest of us, we run this sneaker gala, took place on October 15th. Thanks to all who supported our classmate Cynthia. And the Houston Emporium Moving Party took place also on October 15th. Thanks to all who came out to support our classmate Kimberly Phipps-Nickel. And the Rho Xi 13th annual, the Rho Xi chapter of Omega Psi Phi Fraternity Incorporated is having its 13th annual golf tournament on November 9th. And no, not November 9th. I can't see can you see the date, Sergio? Saturday, October 29th. There it is, on Saturday. So contact Dr. Portia if you would like to support. You can go play golf and then go home and watch the Astros. Or go to the game and watch the Astros. November Happy Hour is Wednesday, November 9th at River House, Houston. Leadership Houston Welcome Reception, November 10th, 6 p.m. at the Ballroom at Tanglewood. Welcoming Ruth Lopez Turley as director and Robert Bozick also as director. Oh, I'm sorry, she is director of Leadership Houston? I'm not sure. Director of the Kinder Institute of Urban Research at Rice University, and he is the director of the Houston Population Research Center at the Kinder Institute. Buffalo Soldiers, National Museum, Veterans Day Brunch, November 13th, 11th a.m., 2 p.m. Please contact Des. Tickets are $75 or $50 if you're a veteran or on active duty. And then the next month's professional series speaker will be Gerald Eaton. Now, I think I have stumbled my way through all of the announcements.
Still haven't figured out how to share my screen yet.
There should be
So
a share button by the leave upper right-hand corner. There should be a share button.
okay.
Share with an up arrow.
Yes, there is, John. The top right.
Because I'm not in the app. I think I'm on the web browser, so that may be the issue.
Oh.
All right,
Okay.
guys, give me a second. I can. I'm trying to email it to you, Sergio, right now.
Okay.
Okay, so I sent that to you.
Okay, got it.
I have a share.
So
I opened the
am
share
not-
tray and nothing is popping up. So
Are you ready? No. Okay. Well,
Uh,
we're gonna keep rolling. I am not an ENT and I am not in an improv class, but I do have some ENT jokes for you guys while they work that out. So the first joke: how do you make a tissue dance? Anyone? Anyone? Put some boogie in it. No.
it's
Sergio
better
doesn't
than
like that
mine.
one? Okay, fine.
Sergio, did it come over?
Yeah, it's up.
Okay.
Yay, now you can be spared my next joke.
Love your joke.
All right, so thank you guys for coming. Sorry for all our fun computer issues. My actual internet went out today for an hour and a half, so I was really wondering if we'd be able to do this, but Comcast came through. So what's an otolaryngologist? Next slide, Sergio. Okay, so we are surgeons that operate on the ear, nose, and throat. We've been around since the 19th century. Actually, in the late 1800s, there was otologist, which is ear, and laryngologist, which is the voice box, the larynx. And actually, it was known as eye, ear, nose, throat until the late 1950s. So there was actually a training program that you did both. And someone figured out that that was too much to actually do things with. So they split the training programs in the late 50s, and then the actual academies that govern this split in 1979. It used to be called otorhinolaryngology, but people didn't think we actually operated. So they made it even harder to say, which is otolaryngology. Head and neck surgery was from the 80s. And if you think otorhinolaryngology is hard, try to say that in Spanish. It's otorhinolaryngologo, which took me about a week in Argentina to get my mouth around that one. Okay, so how does one get here and why ENT? Well, real quick, on ENT, I really enjoyed the fact when I was in medical school that I could take care of all different ages in ENT. So I see, infants from 2 weeks old, little kiddos that are 6 months old and need tubes, all the way to people that are 102. So that's kind of fun. I can see all ages. And when we talk about, how does one get here? Next slide.
I let you have control, Doc John.
What do I need to hit for that?
There you go.
All right, do it. Turn. It's not going to let me do it. So I will stop control. Gotta love Max. Okay, so lots of school, right? So I had to go to 4 years of undergraduate, 4 years of med school, 1 year of internship, and 4 years of residency. Next slide. Okay, so undergrad major. Everyone always asks what to study if you want to go to medical school. And I tell people that don't be a straight biology and chemistry major, that's especially if you know kids that are thinking about doing it. Everyone is going to take lots of science classes in med school. Unless you want to do research and get an MD, PhD, take something you enjoy, go to college, explore, learn to write, take science classes, take business classes if you really want to be a good doctor, because most of what we do is, we're managing a business and none of us have any idea how to do it when we get out of residency because we have no classes. So I always say, make sure that you actually take some classes in business and something else that you really love, and then go forward into med school with that knowledge to make you a more well-rounded person. Let me try that request control again. I think I saw where it popped up on the screen. No, never mind. All right, next slide. Okay, so med school, it's 4 years. This is sort of shows how many books you have to read to get through medical school. It's a lot. It's 4 years. You do 2 years in the classroom. You do 2 years of rotations where you go and you spend, 3 months doing general surgery, 3 months in internal medicine, family practice, obstetrics and gynecology. So it's pretty comprehensive, and a lot of the programs now are incorporating patient care in the first year, so you don't have to spend 2 years like I did in the classroom with books before you actually start to interact with patients and make diagnoses and actually get some experience in the hospital. Next slide. And occasionally we did have some fun along the way, just sort of like fourth year fun. We did some traveling. We all like to dress up. Yes, that's me as Green Lantern. All right, next slide.
Wait, hold on. You're Green Lantern? I'm trying to get a good look. Oh, there you are. That's
there. I'm in the bottom. I'm Green Lantern. Yeah.
Okay. The important stuff.
And a little bit about residency. Everyone that goes into a residency, which is the part of the training where you learn to be an actual doctor, like you get your medical degree, you have a basic training, but to actually go through and learn how to treat people, you have to do a residency. The first year is called an internship, and no matter what you do, you have to do 1 year of internship. It depends on what you go into. If you're in medicine, you do a year of medicine. If you're in surgery, it's surgery. Pediatrics is that. But some of the other programs like radiology, you could do a transitional year where you do a few months of different things. And then after that, you have at least 2 more years of residency. Of note, you need 1 year of internship before you can get an actual license. So there are people out there that will do a year of internship and they go hang a shingle and, do weight loss clinics or something like that. For me, I did 4 more years of residency. And then after that, there's a fellowship, which is like, say, a cardiologist. So you do 3 years of internal medicine and then you do 3 years of cardiology. Or if you're a pediatric cardiologist, you do 3 years of pediatrics and 3 years of cardiology. So all of the more advanced specialties end up having to do some type of extra training like a fellowship. Next slide. Oh, and so basically what I want to do today is just kind of talk about what I treat and then maybe give you all a few tips and pearls on things that you can do at home for common situations that I see that I tend to tell people about a lot. So next slide. Okay, so I treat the ears, right? Ear, nose, and throat. So let's go over the anatomy real quick. There are 3 parts of the ear. There's the outer ear, which is the ear canal all the way to the eardrum. There's the middle ear, which is the eardrum and the ear bones. And then there's the inner ear, which is the organs of hearing and balance. So things that I treat in the outer ear are ear infections like swimmer's ear, wax in the ear canal. The middle ear is you can get infections behind the eardrum. You can get fluid there. You can get negative pressure when you fly. And the inner ear is hearing loss, ringing in the ears, and vertigo. Next slide. Okay, so swimmer's ear. Lots of people get it. You get outer ear infection. It can be quite painful. And so my big soapbox, one of my soapboxes today is don't use Q-tips. I know everybody loves to use them, but all that does is shove the wax further down in there. And then when you use a Q-tip after getting out of the shower, that skin in the ear canal is so thin that it rubs it raw, and the bacteria in the water get in there and cause an infection. Swimmer's ear can also happen like it sounds. You get it from swimming in a pool that's got all kinds of nasty stuff in it, especially in lakes or the ocean. So how can you keep that from happening? Well, you can put a mix of rubbing alcohol and white vinegar together and rinse your ears out with it. And it's one of those things where it's a lot cheaper to do that than to buy the stuff over the counter, because that stuff is about $7 for a tiny bottle. This, if you pay $7 for the rubbing alcohol and the vinegar, it'll last you for 2 years. And it's something we actually used to do at camp, so it works great. If you get a swimmer's ear, right? If you get pain in your ear and it swells shut and it's draining all kinds of stuff, then you need to get seen and get on an antibiotic drop, because that's the best way to treat it. If you go to urgent care clinic and you have an outer ear infection and they give you oral antibiotics, it's not going to work. And I see that fairly often. Topical drops are very safe, and they're 100 times more concentrated than you'll ever get in your ear canal than taking it by mouth. So that's why we use topical drops, because they work so much more quickly and they work better. Next slide. Wax in the ear canal. So yes, everyone gets wax in their ear canal. This is where I talk about Q-tips again, and ear candles, because if you think about it, the Q-tip is the same size as the ear canal. There's no way to get around it and pull stuff out. It just packs it further and further closer to the eardrum, and so it makes it worse. And surprisingly, you only need a really thin layer of space for sound to travel through to get to the eardrum. So you can have an ear full of wax, and it just takes just 95% can be blocked, and you can still hear. If it gets completely blocked, or if it gets wet and the wax expands, that's when, especially like when you go swimming or you get out of the shower, that's why the ear gets blocked up. So what can you do for it? The thing that we recommend is to use mineral oil or baby oil, put it in the ear canal, let it soak in there for a day or two. You can actually just leave it in there for like a few minutes, and then use warm water and a baby bulb syringe to flush it out. The oil makes the wax less sticky, it makes it slippery, and a lot of times it'll come out. And if it's really bad and you do that for 2 or 3 days in a row, it will probably take care of it. The problem with ear candling is it just melts the wax in there in a different pattern. And every once in a while you see where people will get earwax that falls, that's hot. Sorry, the candle wax will fall into the ear canal and burn it. That's not a good thing. Next slide.
Dr. John, you have a question. Dorita is asking, how do you rinse it? I think she's talking about the swimmer's ear combination. How much is too much?
Oh, it doesn't matter. Just as long as it gets in there and comes out, it's not going to hurt
What
anything.
do you do? You turn your head sideways and just put it in?
Yeah, just like let it run in there and run out for the swimmer's ear. It just gets in there. The alcohol dries it out, and the vinegar is acetic acid, right? It's an acid. It will kill fungus and bacteria. So it's actually does 2 different things.
My daughter's camp used to use those squirt bottles that you can pour ketchup or mustard in. And
that's
then
exactly
squirt
right.
it in the ear that way.
Yep, that's exactly right.
Oh, sorry. Is this the right one?
One more, back.
The buttons keep disappearing. This one?
Nope, we're going forward. We need to go back one or two more.
I can't see the.
Did they go away?
Am I going the wrong way?
You're going the wrong way.
I'm sorry, the arrows have disappeared, so I'm blindly clicking. Still the wrong way? Yes, those are all the wrong way.
Oh, there they are.
I'm sorry? Oh, there they are.
They
Yes,
just showed up.
they showed back up. How bizarre. Okay.
One more. All right, hearing loss. So a little bit of hearing loss. Everyone tends to get hearing loss as they get older. Hearing loss is something that really affects a lot of people, especially as we start getting a little bit up in age. Noise exposure. So everyone that gets exposed to noise in their lifetime, the inner ear has a membrane that has little tiny hairs that line it, and it's kind of circular, and it starts thin at the top and widens out as you get towards the base. And the higher frequencies are more sensitive. That area that gets stimulated by the higher frequencies is more sensitive, which is why the higher frequencies break down with more noise exposure over time, which is why you have high frequency hearing loss as you get older. So noise exposure from concerts, from shooting guns all affects the inner ear and makes you have hearing loss. That's why we talk about wearing hearing protection when you shoot guns or go to concerts. Genetics, a lot of people are either born with hearing loss, or they're just because it's in their genes, they're more likely to have hearing loss as they get older. And when you get older, the part of the inner ear in the high frequency breaks down more, and so you're more likely to have some hearing loss. Everyone's different. There are people that make it to their 90s with no hearing loss, and there are people that either because of their genetics or because of noise exposure in their 50s and 60s can have a lot of hearing loss. The important thing is to get hearing aids sooner than later for several reasons. One, it helps you hear better, and it makes your loved ones less upset with you when you ask them to repeat themselves all the time. Two, it actually helps to protect your hearing, because if you don't stimulate the nerve where it actually hears, just like if you have muscles and you don't use them, that they kind of shrink. Same thing, if you don't stimulate the nerve where you can actually hear, then you're more likely to get hearing loss worse, faster than it would otherwise. And especially for, like, in our generation, our parents, people with hearing loss tend to withdraw. They can't understand conversations, so they don't tend to interact, and they're much higher risk for dementia and depression. Depression and dementia, sorry. So that's the thing we try to impress, is that if you got even mild hearing loss, it's important to get in hearing aids sooner than later, because if your ability to understand words, so when we do a hearing test, you listen for the beeps and click where you hear it, but what's more important is being able to understand words. And that signal from the ear to the brain, that the sound travels up, if you can't understand words, let's say we do a test and you only get 80% of the words right, doesn't matter how much we turn up the noise of it coming in with a hearing aid, you're not going to be able to understand it. And so that's why it's important to wear hearing aids sooner than later, because if you don't stimulate that nerve, it's going to get worse. And when you get down to under 60% word understanding, we're talking about something like a cochlear implant, which is a surgery to implant something into the inner ear. Now, that sounds great that you could hear better, but everything actually sounds like Mickey Mouse with a cochlear implant. It works, but it's not the same. Let's keep going. Next slide. Tinnitus, I think. Okay, so tinnitus is a noise or ringing in the ears. A lot of people have it. If you hear a noise in your ear for about a minute, your hearing goes away and comes back, and you maybe feel a little fullness in the ear, that's actually normal. It's called transient ear noise. It's something that everyone has. It's nothing to get excited about. But we worry about ringing when you start having it for more than 5 minutes at a time. It happens multiple times a week, and it becomes bothersome. Tinnitus is actually related to hearing loss. When you lose hearing, there's a lack of input from the ear to the brain. This lack of signal makes the brain get confused, and it starts creating this noise only you can hear. Now, unfortunately, this is one of the things in ENT that drives people nuts, is that I don't actually have a pill for this. It's so complex in the inner ear that we don't know why it happens. We know it does, but we can't target it with medication. So we talk about noise masking, keeping low levels of some type of noise, like a radio or TV or music, on in the background, or at night, which is when it's the worst for most people because it's quiet and there's no sound, playing the sound of the ocean or a white noise, like it's called a white noise generator, will actually help quite a bit. And all our favorite things in life, like caffeine, make it worse. Stress makes it worse, and so do high doses of things like aspirin, Motrin, or Relieve. Now, things to worry about is when you only have ringing in one ear. If you have a sudden onset of ringing or a sudden onset of hearing loss, that's concerning. You could have a viral infection in the inner ear that can knock out your hearing. So if you had a sudden onset of one-sided ringing, I'd want you to come and be seen in the office for that. Next slide. Okay, so the other thing we do, I don't do allergy testing myself in the office. We actually have allergists that do that. Some ENTs do. But just to give you some quick things that you can do when you have bad allergies that are now over the counter. So Flonase is a steroid. We've probably all heard of that. But the new one is an antihistamine. So antihistamines actually stop the secretion of what's called histamines, which drive that molecule makes you sneeze, have runny nose, and congestion. And you probably heard of Zyrtec and Allegra. That's ones you take by mouth. But Astepro is one you spray in the nose, and it works really well in combination with Flonase. So if you've got bad allergies and there are only certain times of the year that bother you, get on Flonase and Astepro at the same time, and that'll make a huge difference. And that's something I write for a lot of my patients and have them try. it actually works better to use Flonase and Astepro than it is to use Flonase and Allegra. So next slide.
And what's there's one drug, it's prescription that has them both.
Dymista. And that's now generic. It's not over it won't be, yeah, they have a generic, so they may actually cover it now. And I haven't written for it in the past because it costs so much for people. So the other thing we do is sinus infections, okay? So if you look here on the green side is a healthy sinus, the red is when they're infected, but you actually have 4 sets of sinuses. So you have ones in the front of the forehead called the frontal, the cheek ones called the maxillary, the ones between the eyes called the ethmoids, and the sphenoid, which you can't see here, but it's in the center of the head. Why do we have sinuses? Well, that's a great question. Some of the theories is that if the whole skull was made of bone, it would weigh a ton more. So by having the sinuses, it decreases the weight in the face. Think of them also, they may have been designed as a crumple zone for when, back in the day, we would, get into fights and your face would get injured. It's a crumple zone to prevent the rest of the face from getting injured, like the eyes or the brain. Again, these are theories, nobody really knows, but that's the thoughts about it. So your healthy sinus, there are these big cavities, but they're really tiny drainage pathways. So all it takes is for those pathways to get blocked before you get sick and get an infection. And the one thing for you to know is, when do I need to get seen for a sinus infection? And when is it just a virus? Because a lot of people get sick for a day or two, have a little bit of yellow drainage, go to the doctor, and they get a Z-Pack. And the problem is that you actually create a lot of antibiotic resistance. And so now you have all these infections that are resistant to all the antibiotics. And to be honest, Z-Pack is like taking candy these days, because the 3 different types of bacteria that commonly cause sinusitis have like an 85% resistance to it. So when is it a virus? When is it bacteria? Well, a lot of times you get sick, you get a viral infection, your nose swells up, you get clear stuff, you can't breathe through your nose. When do you need to go see a doctor for this? Well, our rule of thumb is that you have to have 5 days of yellow drainage, and you get worse at day 5, meaning pain in your face, pressure, feeling terrible. A lot of times as a virus, at 5 days, you'll start to feel better. It'll start going from yellow to clear. And that's when the things that I'll just talk in a sec will help with it, but you don't need an antibiotic. So if you have 5 days and getting worse, or if you have yellow drainage for 10 days is when you would get on an antibiotic to get treated. What can you do at home to help keep you from, 1, getting worse and getting a bacterial infection, and 2, to help the virus get better faster? Saline washes, which you'll see in a second, they're your friend. They help get all the mucus out of the nose. Flonase, and then Mucinex to thin the secretions. Next slide. So real quick, chronic sinusitis, the CT scans, this is what an actual X-ray sort of your face looks like. White as bone, black as air, gray as everything else on this slide. And the gray is healthy. That's what it's supposed to look like. This is air in the sinus, and there's these tiny little pathways where my arrow is. I hope you can see that shows the opening to the sinus. You can see they're really small. Well, when you get lots of infection, it gets all gray like this, and that's bad. And that's when we might talk about doing something more invasive for that. But how do you know what a sinus infection is? What symptoms do you have? You're going to have congestion in your face. You're going to have lots of nasty, thick, yellow, foul-smelling stuff out of your nose, and lots of pain and pressure. We call it a chronic infection if you have it for more than 3 months straight, or if you have more than 4 to 6 infections a year. That's when you need to get seen and get something done about it. So what is medical management? What do we do first when you come in for a sinus infection before we talk about surgery or something like that? Well, one, you have to have the criteria we've said before, meaning 3 months straight of infections or 4 to 6 infections per year. But the first thing we're going to do is give you 3 weeks of an antibiotic. Sometimes we'll culture to see what it is, meaning put a swab in your nose, send it off to pathology, and make sure that it's not some type of resistant bacteria. We'll have you do these saline washes and a nasal steroid. Next slide.
Quick question.
Yes.
Would you recommend for people who are having sinus issues that they squirt the Flonase or the Nasonex, whatever, their steroid into their distilled water? Because that's what I use budesonide. That's because I have chronic like really, really chronic sinusitis. But would that help to get the steroid actually into the sinuses?
It's not concentrated enough for that.
Okay.
So that's why we do the sprays first, and then if you're really bad, then you do the rinses. So this is the saline rinses. They're your friend. I know it looks kind of gross. I've done these. I know Shannon does these, but I will definitely be the first person to recommend them. NeilMed, the guy that created that is probably sitting on an island in the Bahamas somewhere because he sells a gazillion of these per year, and it's like the main brand on the market. So what do they do? So you're going to take that bottle, you're going to get distilled water because, again, it's very rare and people do use tap water, but there have been a few reported cases of an amoeba getting in there in the water and getting into the brain. So that's why that says to use distilled water. I'm sure people still use the regular rinses from the tap, but just know that if you haven't had sinus surgery, the risks are highly, highly unlikely that you would do that. But that's why people are told to use distilled water. So distilled water in the microwave, heat it up, add this packet of salt to it, shake it up, and you stand over the sink, tilt your head down and squirt, and it goes in one nostril, out the other. So what does this do? It gets all the mucus out of your nose, all the infection. It gets all of those dust and pollen out of the nose. And there's these little tiny hairs that line the sinuses. They line the lining of the nose, the actual nasal mucosa was what we call it. They beat and they clear the mucus. And so the whole point of doing the saline rinse is actually helps them beat faster to make all of the mucus get out of your nose. And because of the salt in the solution, it actually moisturizes the nose. So I know you've got water in the nose in the pool. That hurts. This does not hurt. It's not something that's painful. Next slide.
Now I'm just going to share that I actually prefer the Target brand of the saline packets to the NeilMed packets, and the CVS bottle is gets you more pressure.
All right, I will keep that in my list. So sinus surgery. So this is just a photo. Shannon knows about polyps, so this is a little polyp coming out of the sinus here. Won't get into too much, but I wanted to do some videos, but they were age restricted on the internet, so I couldn't bring them up to show you anything. Sinus surgery is something that's indicated when you fail medical management. When you have done 3 to 4 weeks of antibiotics, you still have this horrible pressure in your face. You got yellow-green mucus coming out. So what we need to do is get a CT scan to see what happens. What's in the sinuses to see what's there and see what sinus we need to target. Sometimes we'll do allergy testing to see if that'll make a difference. But if all that's been done and you're not getting better, then you go to the operating room, and I use a scope that goes in the nose, and I actually take down the bone that's in these little openings of the sinus here. I take down the bone, get it open so the mucus can get out, but also so the sinus can drain and circulate. And after that, you can do these topical rinses like Shannon does to get in there, to get the mucus out, to get the infection out, and to treat it with topical steroids and antibiotics. So sinus surgery has some risks. So we don't take it lightly. Something new that you may hear about is balloon sinuplasty, is where, as in this little photo on the bottom, you actually can do it in the office. You run a little device with a wire into the sinus. You confirm where you are because it lights up on the face when the light probe gets into the sinus, and then you dilate the balloon, and it actually gets that sinus open and gets it to drain. So for some people with more moderate infections and moderate sinusitis, it'll work. For people with polyps or severe infections, it's just not going to be enough. And some people may advertise a lot on the radio that balloon sinuplasty will cure lots of things like allergies, breathing issues, and things like sleep apnea. It doesn't do any of those things. So just in case you've seen that on the radio, that's not something we necessarily recommend. Next slide. Okay, real quick, I'll talk about if you can't breathe through your nose, the 2 main reasons for that, besides allergies. That's pretty common for people that come in. They're like, I can't breathe through my nose. The middle part of the nose here, see this little crooked area on the CT scan. It's called the septum. It's cartilage and bone. So the outside of your nose quits growing around probably 16 to 18. It's earlier in women than men. And what happens is this cartilage and bone will still keep growing, and it doesn't actually go out straight. It shifts to one side or another, and you get this deviation. You can see here in the photo, this like sharp spur, this thing sticking over into the nose. It's supposed to be straight. You're supposed to be able to see all the way to the back. And so this spur is something that has to be surgically removed. And I'll show you on the next slide about that. But the other things that cause trouble are these things on the side of the nose called the inferior turbinate. This photo shows a turbinate on this right side that's very shrunk. It's very open. Allergies can make it swell up. And some people can have what we call a non-allergic rhinitis, where it's not actually allergies. They just react to all the dust in the air. Or some people, they call it skier's nose. When it's cold, your nose can swell up, or they can just react to certain foods. But that's why nose sprays help shrink this. And I can surgically shrink that in the office or the operating room. Next slide. Now, you may have heard people talk about, I got my septum done, and they come back, their face is all bruised, and their nose looks different on the outside. That's a rhinoplasty. That's a cosmetic surgery. That's not a septoplasty, okay? A septoplasty is where you make an incision with you asleep on the inside of the nose and take out these parts of the cartilage that are crooked. Now, sometimes we'll take them out and try to straighten it. Sometimes you actually have to take all of it out and leave just a little bit behind. But the whole end result is that it makes it more open where you can breathe better. And these things are the turbinates. So you can see there's bone in there. We can actually shrink that in the office or operating room, and it gives you way more room to breathe in the nose. So if you have trouble breathing in the nose, that's why you would see an ENT. Next slide. Real quick, snoring and sleep apnea. Snoring is a big thing. It bothers people quite a bit when you have a bed partner that snores. That's why people come into my office, is that says my spouse, my partner says I snore really loud and I can't sleep because of it. Well, it's actually something that's a real threat to the health. And so 20 million Americans have moderate to severe sleep apnea that at a minimum. And the thing about sleep apnea is we measure how many times you stop breathing per hour. Moderate is 15 to about 30, severe is 30 events per hour or more. So that means you're stopping breathing every 2 minutes. So you can imagine if you wake yourself up every 2 minutes, you're not getting good sleep. And what happens is that in order to get enough oxygen, because your oxygen starts dropping because you're not getting enough breath in, is the blood vessels have shrink down and you start having high blood pressure. And the end result is that you have a higher risk of heart attacks and strokes because you got high blood pressure. And what this means, when you have more than 30 events per hour, your survival rate from heart events at 10 years is 65%. Meaning you have the same survival rate as a stage 2 cancer, meaning, it's a serious effect on your life. So that's why we're really talking about sleep apnea and people that snore really loudly, they stop breathing at night. If it's somebody you care about, I'd recommend they get looked at. And it's not like we used to do where we sent you to some sleep center, you had to sleep in a weird place overnight and get hooked up to like 10 different things. It's a lot easier now. You can do a sleep study at home. They even have some that goes to your wrist and your finger and on your chest, and that's it. So it's real easy to get tested for this now. It's not a huge hassle like it used to be. Next slide. So what happens if you have sleep apnea? Real quick, 3 ways to treat it. The mainstay is CPAP. The whole goal of any of this is the tongue falls back at night. It collapses the airway so no air gets through when the tongue falls back. So CPAP blows air through the nose, so it opens the airway, pushes the tongue forward. So you get air down into the lungs. For people that have mild and moderate sleep apnea, there's an oral appliance. It's something the dentist makes to pull the jaw forward. Same thing, pulls the tongue forward, air gets through. And for people that fail that, there are new surgical options. For those of you that watch late night TV, Inspire is the new thing. It's probably everywhere these days. I actually do that surgery. It's an implant that when you breathe in, it makes a signal to the nerve that moves the tongue to push it forward. So again, getting the tongue forward is what treats it. And that's why we really, talk about the CPAP and oral appliance first, because it's non-invasive. Next slide. And question?
I have a question.
Sure.
About that. So I was nervous about getting it because I've had like a major surgery every year for the last couple of years. And so do you go under for that implant?
For the Inspire?
Uh-huh.
Yes, you do. It's about a 2 to 3 hour surgery for that.
Uh-huh. Okay. All right.
If you ever want to talk about it, let me know, because I do those. I can talk to you about it. And then getting towards the end, thyroid nodules. So the thyroid is a gland here in the bottom part of the neck. I do see people with thyroid nodules and thyroid cancer. So the thyroid regulates your hormones. So low thyroid, you get kind of tired. High thyroid, it makes you hyper. Why does the thyroid make nodules? Nobody knows, but it just likes to. In the old days, starting like 20 years ago, we would be more likely to take out thyroid nodules. One thing they have discovered by going back and looking at thyroid cancer, the normal type of thyroid cancer that the majority of people get has a 5-year survival rate of 98%. So you may hear someone you know has thyroid cancer, know that almost everyone does well with this. It is not something that is going to kill you. It can spread and cause issues, but it's not something that we consider to be as life-threatening as when you say the word cancer usually is. And we find a lot more thyroid cancer these days than we used to because people are getting more CTs and MRIs for different things now. It's common to get a lot more CTs of the chest and the neck, and they find these thyroid nodules incidentally. I mean, if you feel on your neck and you feel something, that's when you get looked at. But a lot of times you're going to get a scan and they're like, oh, we found a thyroid nodule. Well, what do you do for that? You get an ultrasound, which is they put a little wand on the neck and they use sound waves to look at the thyroid and see what's there. And if you have a nodule, there are special criteria now that tell us whether you need to have a needle biopsy or not. And if you get a needle biopsy, we have a lot more advanced methods of knowing whether you need something done, meaning we can do genetic testing now to tell if you have a higher risk of cancer, where in the old days, we're like, well, it's a follicular nodule, 20% chance of cancer, we got to take it out. Now we can do a genetic test that tell us, hey, there's an 85% risk of cancer, or there's a less than 5%, we can just watch it. Next slide. So you have two lobes of the thyroid, and like I talked about, there's a left and right side. We're detecting more thyroid cancer, and they've actually found in studies, and especially in Japan, they're actually studying where if you have a thyroid cancer, it's called the type that's papillary. If it's up to 2 to 3 centimeters, you can actually follow it because the risk of it spreading to other areas or actually causing something to die from that are very, very small. They've found that there are plenty of people that end up, they do autopsies on people and they find large, decent sized thyroid cancers of 2 centimeters that had their entire life and never caused a problem. So that's why we're much less aggressive now, because surgery has risks and it's not something we take lightly. We also know that now you only need to take out a half of the thyroid instead of all of it like we used to, which protects some of the things at risk. So this is just a picture of something I do. I take out either the whole gland or half a gland, and that's something where a lot of times you can go home after taking out half the gland and have minimal pain and not need a lot of anything after, like thyroid hormones. Like a lot of times when you take out the thyroid, you're not going to have any thyroid hormones. You'll have to be on medication. If we only take it half versus whole, then you don't need a medication after that. Next slide. And the last thing I want to talk about here is head and neck cancer. So that's something that the main person that needs to coordinate head and neck cancer is the ENT. So that's, if you have a mass in the neck or something weird in the nose, throat, or the larynx, then you come see an ENT like myself, and we take a look, we do a biopsy, and get you started on treatment. It's actually interesting that 20, 30 years ago, we used to see these people that had cancer in the tonsil, and they would do a lot better with radiation therapy than other people. And that what we now know is that, everybody associates head and neck cancer with smoking. Smoking has gone down. So we're seeing less cancer for that. What we're seeing more cancer from is the human papillomavirus, HPV. So the same thing causes cervical cancer, it can cause cancer in the throat. And it's always a fun conversation to have with patients when you tell them that it's a sexually transmitted disease that caused this, but that's the truth of it. You can get exposed at any point in your lifetime to HPV, and especially it happens when you start becoming sexually active. And it does can get passed to the HPV to your partner, but if you're in a long-term relationship with someone, it's not something we ever tell people to get worried about with that, because you've been exposed so many times that it's not something that it's likely to cause cancer in someone else, but it can. The good thing to know is that we are detecting more of head and neck cancer now. If it's caused by the human papillomavirus, it actually does better. People have better survival rates and better outcomes with HPV. They need less radiation, they need less surgery, they do better. So this is my other soapbox today, is there's a vaccine for the human papillomavirus. It is something that is FDA indicated for girls to prevent cervical cancer, but it also works for boys as well. And it works to prevent cancer in the head and neck. So it's something I highly suggest doing. It is now approved for ages 9 to 45. So it's something to think about at any age to get this. You can talk to your doctor about it. I actually had it done right around the term age 45 as I was reading about this, because if there's even a chance to down regulate the HPV virus to help prevent it, I think it's something that's worth doing. Next slide. And just finishing up real quick, I do 4 days a week in the clinic. I do 1 to 2 half days per week in the operating room. So that's kind of my normal schedule. And then just to close up real quick. Next slide. Thanks for sitting through this today. I hope you got a few tips and things to do at home just to go over that. This is my soapbox again. Don't use Q-tips. Flushing your ear out with warm water after putting some oil in it with like a little eyedropper will help to get the wax out. Use your nose sprays. The Astelin, the Astapro, and the Flonase will help treat your allergies. It may keep you from going to the doctor. Saline washes are good for you. And the one thing I forgot to tell y'all is that people always ask about what they can do to keep their ears from getting blocked up on a flight. So Afrin, spray it in the nose, and take a Sudafed an hour before a flight. And that will actually help cut down on the pain and pressure you have when you're flying, or if you're going to fly and your nose is congested, that'll help prevent you from getting pain when you fly. So I'll take any questions real quick from the audience. If not, appreciate you spending some time with me this lunch. And I hope to see you all at the happy hour coming up next week.
Yes, you have a question from Heidi. She says she knows someone who's done a sleep study, received their CPAP, when they have severe sleep apnea. They still complain of lack of sleep and high blood pressure. Other than surgery, are there any more options for this person?
I mean, if they have a CPAP and they're using it and they're not feeling good, they need to make sure that the CPAP is actually effective. And so you can get a download sent to your doctor from your CPAP machine that will tell you if it's working. And if it's if it's effective and working, then it's possible that there's another sleep disorder going on. And so that's when it's seeing a doctor that's board certified in sleep medicine to see if there's some other sleep disorder is the next step. If it's because they're not wearing the CPAP and they're ripping it off at night, then there is the oral appliance to pull the jaw forward is an option rather than looking into surgery. And you can wear an oral appliance with a CPAP for some people.
There are no more questions in the chat. Sergio, I think, has a question. His hand is raised.
Yeah, real quick, Dr. John, thanks so much for doing this. Maybe I missed this in the presentation, but you could have been a doctor in all sorts of specialties. Why did you select ENT? Why this area of medicine?
Well, I actually had surgery on my sinuses when I was in college, but I actually grew up in the allergist and ENT's office because I was sick all the time. So I have personal experience with the specialty. And I kind of liked the people that I went to and the doctors that were in it. And I liked the range of things that I treated. So that's why I actually ended up deciding to go into it.
Okay, cool. Interesting. You had some growing up kind of life experience with it. And you wanted to help. You want to be on the other side. That's cool. Well, thanks. Any other questions from the group? My hand
I
out.
do.
Yeah, go ahead.
Yeah. So I have a CPAP, and my question is, I really try to be, if I can, as natural as possible on most things. So I'm not a big proponent, of always going to a pill first and stuff like that. However, my allergies are so crazy. Yeah, I'm definitely I'm like montelukast, famotidine, cetirizine every night. And when I don't, I have hives, I itch. And so I don't get a good night's sleep because I'm itchy and all of that. But that just feels weird to me, especially because of how long I've done it. And I just don't want to do that for the rest of my life. And so interested in knowing if there is, are you ever okay? And then number two, the distilled water and things like that, it eats my skin. So I wonder if there's other things besides that CPAP.
I mean, for the CPAP, besides the oral appliance, the next step would be Inspire. The other surgeries for sleep apnea, when you take out the tonsils and pull the tongue forward, are not very fun to go through. So that's something I wouldn't recommend.
I haven't seen
Um,
that be successful for anybody.
yeah,
They
no,
got
that's why
bad gag reflexes and stuff like
yeah,
that. Yeah.
that's why I'm doing the Inspire now, because it's a better option and it's a little bit less risk. You know, the problem with the urticaria is that I don't know if shots work as well for that, right? For allergies, shots long term do make a difference, but if you have the itching, it's a little bit different. And again, I'm not the allergist is more the expert in that than I am. But the only other thing I could think of would be to get on shots for that. Now, those 2 nose sprays, if it's congestion in the nose, the Flonase and the Astapro, those do work, and that's something I would think about doing.
Yeah, I had those. I just stopped. I just felt like it was weird, like doing that all the time. But yeah, thanks.
And
I do it all the
Great
time.
presentation. This was all good.
Dorita? Can you
Yes.
hear me? Oh,
Yes.
you might ask your doctor about trying to stop your Montelukast cast, because mine just told me it's cheap, so they prescribe it a lot, but it really only has noticeable symptom relief in about 30% of patients.
And that's true. Montelukast is not a cure-all for that. It's an add-on if nothing else works, but it's more for asthma than allergy, so you might not need it.
I have a little asthma, but yeah, there are times, yeah. And I know, like at night, if I skip it, if I'm somewhere else and I don't come home, I mean, like and I don't like that. That feels very dependent to me. That's very crackish to me. So yeah, I'm interested.
Well, it's not
in
a habit forming, it's but try talking to them about whether shots would work for you, because allergy therapy does work.
Okay, awesome. Thank you.
All right. Well, thank y'all. Appreciate it.
Good job.
I'm gonna head off to clinic, and I hope to see you guys next week.
Thanks, everyone.
And thanks, Shannon, for hosting. You have a good day.
Thanks, Shannon.
Good job. Good job.
All right.
Take care.
Bye.